afternoon, everyone, and welcome to the launch of our first lunchtime series of the Research and Policy Committee of the Public Oral Health Forum. I'm Tamsin, a public oral hygienist and a proud National Council member of the Public Oral Health Forum. The Public Oral Health Forum strives in its commitment to ensure equity in oral health, well-being and dignity for all, and additionally ensuring all oral health for populations at all levels. Today we are kicking off the first lunchtime segment with a discussion around public oral health professionals' role in research. Joining me today to discuss this hot public health topic is academic professor extraordinaire Prof. Robert Barrie. Professor Rob Barrie grew up in Johannesburg and matriculated from St. John's College in 1971. He obtained his BCH degree from the University of Stellenbosch, and he worked in Hammanskraal from the years of 1978 to the years of 1980. He worked at Iders Valley Clinic in Stellenbosch from 1980 to 1983 and obtained his BCHD honours in the same year. Prof. Barrie also published 22 publications in various academic journals and also 18 from the IADR. Should you be interested in joining us for these segments, join us every last Thursday of the month as we indulge in policy and research and how it will be valuable to you as a public oral health professional. Should you be interested in becoming a member of the Public Oral Health Forum, please have a look at our social media pages on LinkedIn at Public Oral Health Forum and on our social media pages such as X and Facebook at POHF. Thank you and see you next time. Good afternoon, everybody. Welcome back. So this is our first launch of our lunchtime series, and today we have our extraordinary Professor Rob Barrie with us today. And a brief introduction was already done. So, Prof, to get us started, we'd just like to ask you, how was your experience working in public health as a dentist from 1978 to 1983? Is that correct?
Yeah.
And another question is, what motivated you to pursue research in public health?
Okay. How long have we got?
We have about half an hour, if you can go
That's
on.
definitely, I'm going to need longer than that to talk about it. But yeah, just as an example, when I started, I worked in a little hospital out at Hammanskraal and did all sorts of interesting stuff, and I really made orthodontic appliances, and as I want to help patients. That's really been the heart of the whole thing. That's really what I wanted to do. When I got to Stellenbosch, and I was working in the clinic at Iders Valley, somewhere along the line I got to the regional office here in Belleville, and I saw the statistics that they are recording from the clinics. And there I saw there was a dentist, no names, no pactoral, in another town, no names, who had 3 times the amount of work that I had done in that period.
Yeah.
And I just thought, but that's impossible. No one can work. I mean, I was there at 8 o'clock and we worked till 4, and I can tell you all sorts of stories about how we used to make sure that our patients came for their appointments and double booked if we didn't think they were going to come. And it just fascinated me. How's it possible? And then I looked at the way they measure the performance, and I thought there's something seriously wrong with the system. They're only counting certain things and adding certain relative value units for those certain things. But what about the people who go the extra mile for the patient? They're not getting any reward for that. It's not even recognized.
Yeah.
The person who really sits with that difficult child to try and restore that tooth, multi-surface restoration, it's much quicker to just pull out the tooth.
Yeah.
And then you can see another patient, and head counts is actually a very poor indicator. The regression coefficient is 0.15 or something,
Yeah.
of total amount of work done. And yeah, I did a lot more research on that at a later stage, but something along the line, I felt there's something wrong here. What can we do? Another thing that sparked my interest was we used to go out to schools to give talks to the children, prevention, right? And I remember once, shame, it's a bit embarrassing, but I gave such an animated discussion of the consequences of dental caries that one child in the back of the class actually vomited.
Oh, wow.
Because I think I laid it on a bit thick. But I mean, we used to do all this work, and you know what it's like.
Yeah.
You go around, you talk to people day in, day out, but you just tick it off, I've done it.
Exactly.
School motivated. But is the school motivated? And so then I thought, but why? I seem to be seeing more kids from some areas than from other areas. Why is this? Should we not? And I was busy working part-time and learning about community dentistry. There wasn't much about ComDent when I was an undergrad. And I was learning about DMFTs and stuff and WHOs and things. And so I went to the boss here in Reed Street in Belleville in the regional office, and I spoke to him and I said, listen, I was just thinking, I just want the go-ahead. Would it be possible for me to go and measure the levels of disease in the different schools? And then I've got a map of the area. I could put it on a piece of styrofoam on the wall, and I could put in pins of different colors based on the DMFT, that I could get an idea of what's going on with caries in my area, and maybe go a bit more all out for the problem schools, if you know what I mean. And he was listening to me rambling on about this, and he was opening his mail, opening his post and nodding and smiling and putting the letter down over there and putting this letter down, nodding. And I realized that he had either no clue of what I was talking about or no interest. What do you want to do? Just go to the clinic and do your job. Yeah. And I often feel that, is that not what the problem is with management? That they don't understand the realities of the person on the ground and the difficulties that you have. So I went and measured my DMFTs. He said, yeah, you can do it, you can do it. So I did it and tried to tailor schools with higher caries to be visited more often. It went on from one thing to another, and eventually when I was specializing, that was my thesis.
Oh, wow.
I was looking at, so why, we just talk at the schools, but does it actually work just to talk to a bunch of kids? And I did 4 different a randomized control trial of one school who just got a talk, the other school who got talk and toothbrushes, other one who got talk and toothbrushes and follow-up, and another one who got nothing. And then I measured the oral hygiene index over a period of time at those schools. There was 1,000 kids or something involved. It was a lot of work. And I proved that talk is cheap. We actually achieve very little just going and giving a little talk to the school. We need a better program. Because I mean, the teachers used to just ignore us. We need to involve them. We need to involve the school. We need to get brushing programs going. Oh, brushes were given to some kids, but others had to do brushing at the school. They were the best. The ones who had brushes, they cleaned their tackies at home. It was nice, but I mean, it didn't really translate into improved oral health. So I was convinced that a brushing program was it was published, but not much changed. I suppose, well, I don't want to get credit for it, but yeah. It was interesting. So the point I'm trying to make is, when you're working at the coalface, don't just look at all the difficulties and all the problems. Just remember, there's a patient that needs help. There's a community with just lots of patients who need help. What's the best way you can reach out to make a difference in their lives? And if that's your motivation, well, then you're going to find ways of helping them. And it sounds bad. Here we're sitting in an academic environment, a whole string of degrees, but that's not what it's all about. It's that passion to help people and to find ways to help them. Go and talk to others. Go and read journals. Now it's easy. We used to go through Index Medicus to find journal articles. Now you just Google. And, well, there are some sites that don't go to ChatGPT, please. But, I mean, you can go and get information and come and talk to people who might be plant a seed. Clinics, people in the clinics have approached us. Why can't we do research to help them of something or other?
Because that's the thing, Prof. Sorry to disturb you, but they basically are saying academics should do research more. It's not us on the ground level.
No. The exact opposite.
So where do you find oral health professionals? I mean, consulting with dentists, hygienists, dental assistants.
Whoever.
So how do you feel, Prof, they can become involved more?
Because they can plant the seed. They can just, at a meeting of, we need to get together and talk, right? Academics they're so busy with academic stuff that often they don't see the real issue on the ground of these kids that are suffering in this school.
Okay.
There's interesting stuff, man. I mean, we've been working in Bottleray for how many years? Did you know that Bottleray is the only area in the Western Cape with a fluoride level of 3.0 parts per million? And why? Oh, we don't know. How do we know? Because some bright spark noticed that there was signs of fluorosis on the kids at the school who were drinking river water on the farm.
Oh, wow.
So, I mean, so you see something, go and ask someone, chat to somebody, maybe we can do a research project, maybe we can go measure something. I mean, that's just something small, but we want the people at the coalface to be involved. We don't want a bunch of academics to come along and just for academic purposes do something. We need to solve problems on the ground.
So you think, Prof, that if you look at daily practice of, community-based education programs and programs as such, so you find that your proactivity is actually much more, it's beyond the scope of a hygienist, of a dentist, of a dental therapist, of a dental assistant. So they can basically do more than just working in a primary healthcare facility. There's more that can be done. Well, as you say,
it maybe needs to be reworded.
Yeah.
That it should be part of your basic employment.
Yeah.
It should be, hey, we want whatever it takes to improve the oral health of the community. And it's not to say, oh, that's not your job, you must leave that to the university. University is too busy with other stuff.
Exactly.
And they don't even know you've got the problem. Talk to us. Us. I've retired, so I don't know what us is, but talk to the academics, plant the seed, and ask them, why is that? It's tough. I'm a grandfather, right? I've got two little grandsons, 7 and 5, and I'm always planting seeds. Ask them questions. I want them to ask questions. I want people to see stuff and think, that's actually very interesting. Why are they thinking that way? What gave people an idea that you must use this to clean your teeth? Find out why. There might be a very good reason, or it might be a misunderstanding of what's in the leaflet that we handed out.
Also true.
So the people at the grassroots level they see what's happening. They're at the coalface, and they need to keep on asking the question, why and what if and why can't we, and then let's take it further. And it doesn't have to be a big PhD thing or even a journal article. We're so obsessed with publications. It's publish or perish. But we need to find a way of researching, but in a way that can improve the health of the community. And I think that's really what it's all about.
That's an interesting question, Prof, because you were saying that most oral health professionals think that it's, or I assume, it's academics' work. If you're in academics, you need to do this. You need to publicize. Sorry. You need to do research. But what we find is that some oral health professionals are hesitant. For instance, they might not pursue a postgraduate diploma or postgraduate training. And also we find that they also
other universities, but at the best university, at UWC. Sorry, guys. We teach research methods.
There we go.
And that's all you need to know to start you off. Yeah, you can go and learn a whole lot of big, complicated stuff for your PhD. Leave that. You've got enough to go and measure something, analyze data. Basically, Excel can do incredible stuff. And then just look at it and just say, wow. And what's more, it keeps you interested in your job and in helping the community. So I would seriously encourage everybody, almost say it should be a requirement. Look, I must say, not everyone is a researcher. I accept that. Not everyone is a clinician. I accept that as well. We're all different. But I would love to see more people involved in asking questions. What's going on? How does this work? It's a number of the things. I mean, take for example, the level of caries in the Western Cape is 3 times what it is in Limpopo. But Limpopo's got something like 3 times as many dentists per 100,000 in this state than the Western Cape has. Well, 3 times 3, 9. No, something's wrong somewhere. Yes, it might be socioeconomic differences, might be, but we've got, in our rural areas, we've got one dentist appointed, and he's got to look after about 4 or 5 towns in the area. I mean, is it possible? How are you going to travel around? And then does the equipment work and all the rest? Find ways of motivating or thinking of solutions to these problems.
Yeah.
I think might be good.
And also, Prof, in terms of academic or even research in the public health space, how do you find that government institutions or even our tertiary institutions can facilitate or help our other health professionals in getting more involved in research?
I think the Public Oral Health Forum is not marketing, right?
Thank you.
But I think a very good example of what can be achieved is getting people together and get people talking. Unfortunately, when you go to many of these dental congresses or whatever, they very much focused on the private sector.
And biomedical approaches.
Because we're the minority, we accept that. We need a forum where we can sit and discuss these issues and have people, if there is research that's done that's relevant to the community, let's talk about it.
Yeah.
Let's share it. But having said that, I don't want to sound like a bitter and twisted old woman, but I've spent many years developing systems which have been terminated by managers who unfortunately don't have the faintest clue about what dentistry is all about. I mean, here in the Western Cape it's even worse. We don't even have a manager for oral health services. And we haven't had for, I don't know, 4 years, 5 years?
More.
Is it more? And I'm got nothing against doctors, right? My daughter's one. I mean, they're nice people. But hey, what they know about teeth is, or oral health, let's go broader, is actually very little. And decisions are made because they measure in the wrong thing, which brings me to my, I'm not selling books, but I came across this book called The Tyranny of Metrics. And basically saying not everything that counts can be counted, and not everything that can be counted counts. And the more you think about it, the more valid it is in terms of what we think is important and we need to count is actually not the stuff that we need to do. A head counts of the number of patients you saw means absolutely nothing. And just because we can count it doesn't mean it actually counts. It's some sort of an indicator. And I've got a thing about the indicators we use in oral health. They freak me out. But I devised a system after much research, years of work, put it into practice. We ran it in the province, best part of 25 years, 23 years. And then we were just told, no, it's not compatible with our systems. We're not doing it anymore. Just record head counts, fill-ins, extractions, and fissure sealants. But we're not measuring whether fissure sealants actually work. And are we not going back to schools and checking, are those sealants in place? Are they still in place? An article was published by a student who found that 92% of the sealants had fallen out a year later. I mean, that's now why? Why? Because they didn't have suction. They didn't have a compressor. So they were just putting in sealants that just fell out. Well, it's all very well to tick the box. We've measured it, we've counted it. That doesn't actually count. So there's so many interesting sort of sidelines involved in doing research. We need to talk together.
And also, Prof, thinking back of what you see, things that can be counted. We're looking at the need for even oral health data and surveillance, for instance. We find that there is a great need for that. And we find that as we approach universal healthcare, within the healthcare system, how do you see that, or public oral health professionals, how do you see their role in research fitting into development of oral health data and surveillance tools, for example? And what can they contribute to the oral health surveillance system?
And there was another system that I had going. We had a system where every clinic used to do sealant programs.
Yeah.
And I had said when they were wanting to implement it some years ago, we met downstairs, and I said, listen guys, we can't implement any preventive measure like sealants, which are relatively expensive and labor intensive, unless we can measure that it's actually having an effect.
Yeah.
Because sealants might be cool, but hey, if the guy's sucking toffees all day, every day, the fissures won't decay, but the rest of the tooth will. So we got to just make sure the whole thing's working.
Yeah.
Measure the DMFT on the 6-year-olds every year. When they get to 12-year-old, measure and see how many of those sealants are still in place, and of those teeth, have we noticed a decrease 6 years later when we measure them at 12-year-old?
Yeah.
I would have thought yes, we should. Unfortunately, the data doesn't show it. Why? Because we stopped going to the schools like we were going to the schools. This was before COVID. There was a lack of motivation to keep the sealant program going. So we pulled the plug on it basically before we were able to measure whether it worked or not. And I know how many sealants we've placed. It's hundreds of thousands. You work that out in rands and cent terms.
Yeah.
We spent a hang of a lot of money on sealants. We don't actually know whether it worked.
True.
So we need oral health professionals at the field to be going out to schools and measuring a thing as basic as DMFT. Yeah, you can go and do DMFSs, and you can do. When I was a registrar, one of the tasks I was given was to do a seminar on oral hygiene indices. How many are there? I found 35, and that was back in the 80s. I'd hate to think how many there are now. And some are so complicated, they're just meaningless. DMFT was invented, published by a South African, so it must be good, right? many, many years ago, it was in the 30s or something, and it's still the world standard.
Yeah.
It's simple, it's quick, it's easy to measure, and then we can see whether we are winning or losing.
True.
Almost what I was doing with my little flags when I was way back in Stellenbosch. But we need encouragement from the management that we can do it. It mustn't be seen as a time waste.
True.
You know, and it mustn't be instead of treating patients with pain. You know, we go to these clinics where there's only one person, and oh no, the next 3 days I'm out at schools measuring DMFT. You guys with abscesses just live with it. No, we've got to find women's help for people in need as well, in pain, urgent. But unless we know where we're going and what the state of health is, are we not wasting our time and our money? I don't know. Interesting.
It's so true what you're saying, Prof. And not just that, we also find that a lot of our oral health professionals, they feel that, they can't be involved in research, that they just do the minimal on the ground. But also looking at, because part of our committee is also part of policy development and getting oral health professionals involved in policy. I mean, look at, I'm not going to even go with what's happening with our oral health policy. But mostly policies, as you know, Prof, they are catered for more upstream levels, you know. Just a question, how do you think, us as public oral health professionals, how can we contribute to the process, number one? And then also, how can our voices be heard in such a dynamic process? Because, it's mostly the guys or us that's on the lower ground. We don't get heard, it's just like, oh, we will miss you, we will go beyond you, and then when we get to policy implementation or policy, and then we're the ones sitting and scratching our heads and
but you just gotta keep on keeping on.
Yeah.
When I was doing my MPA, I looked, because I'd worked back again, I experienced at Stellenbosch, we were charging patients a nominal fee to attend the clinic, and then at the end of the week we had break-ins in the clinic because people were looking for the money, and I used to have to take it down to the old divisional council in those days, cash it in and get proof, and it was a lot of work for that amount of money. And so I actually made a suggestion. Why don't we actually provide the service free? The horror, the looks of horror. I remember, just for a joke, the guy said to me, go and talk to this guy up on the head office in Cape Town, in the department. Go and speak to this guy on the 16th floor in finance. I went and presented my thesis and told him that, you know, we can do this, you should actually do it free. And the reaction was, it was like, you know, but that's totally unacceptable. And I said, but think about it. You'd save us a lot of time, you'd remove a barrier, and you'd make the service more accessible.
Yeah.
When patients, and this is an important point, when patients have got nothing to do, they don't choose to go to the dentist.
Policy development and getting oral health professionals involved in policy. I mean, look at, I'm not going to even go with what's happening with our oral health policy, but mostly policies, as you know, Prof, they are catered for more upstream levels, you know. Just a question, how do you think, us as public oral health professionals, how can we contribute to the process, number one? And then also, how can our voices be heard in such a dynamic process? Because, you know, it's mostly the guys or us that's on the lower ground. We don't get heard, you know, it's just like, oh, we will miss you, we will go beyond you, and then when we get to policy implementation or policy, you know, and then we're the ones sitting and scratching our heads and like,
but you just gotta keep on keeping on.
Yeah.
When I was doing my MBA, I looked, because I'd worked back again at experience at Stellenbosch, we were charging patients a nominal fee to attend the clinic, and then at the end of the week we had break-ins in the clinic because people were looking for the money, and I used to have to take it down to the old divisional council in those days, cash it in and get proof, and it was a lot of work for that amount of money. And so I actually made a suggestion. Why don't we actually provide the service free? The horror, the looks of horror. I remember, just for a joke, the guy said to me, go and talk to this guy up on the head office in Cape Town, in the department. Go and speak to this guy on the 16th floor in finance. I went, presented my thesis, and told him that, you know, we can do this, you should actually do it free. And the reaction was, it was like, you know, but that's totally unacceptable. And I said, but think about it. You'd save us a lot of time, you'd remove a barrier, and you'd make the service more accessible.
Yeah.
When patients, and this is an important point, when patients have got nothing to do, they don't choose to go to the dentist. Sounds, we'd like them to, but they don't do it just for fun. They don't do it because they've got nothing better to do. They do it because we've motivated them to come and seek treatment early, or to prevent treatment or something. It has a definite biological benefit, health benefit. So why are we putting obstructions and not allowing them to come easily? And we just need to keep making our voice heard.
Yeah.
When eventually they did say it would be free, I thought, yes, maybe someone read the thesis. I doubt it. But policy analysis is another one of my favorite topics.
Okay.
It's a lovely field.
Yeah.
And there's always inputs that you can make. And you know what? If people don't want to listen to you, just keep on. Just keep on gently pointing out the reasons why you're saying that, what your experience is at the grassroots level.
So true. Because
it's all very well to have this overall policy, I forget what it's called, at the top level. And it sounds all very good, but operational policy doesn't meet that policy.
Yeah.
And you need at each level to have policy, but it must be focused and targeted and based on the experience or where we want things to happen on the ground. Otherwise, you can have the grandest looking policy, but hey, somewhere along the line the equipment also has to be maintained. You know, otherwise what are you doing? It sounds good, but it's actually rubbish. It doesn't work. And here in the Western Cape, studies we've done show that only 30% or so of the clinics are able to provide the basic services because they don't have x-rays and they don't have suction, the compressor doesn't work. Well, any policies that don't address those issues are actually rather meaningless and so frustrating for the person working every day, wants to be able to help this kid fix that front tooth. No, sorry, suction doesn't work, pull it out. No, man. Huh?
So you're saying, Prof, that we as oral health professionals need to actually start becoming more vocal?
I think so, yes. But it doesn't, I'm not saying we must all go on strike. I'm not saying we must throw our syringes at the managers. But if we had like a forum
like this,
where we can get people, and our experience in the Western Cape might be totally different to what's happening in KZN. Maybe they're onto something brilliant there.
Yeah,
Are
true.
we talking to each other?
Yeah.
Can that idea not be implemented here?
And now we're meeting each other halfway. Exactly.
Yeah, and we could. My heart is with the community. It's the people on the ground, the citizens of our country are entitled to a service. Are they getting it? And are we giving them the best we can?
Mm-hmm.
And I'm as concerned for the grassroots workers. Been there, done that.
Mm.
I remember at a hospital at Hammanskraal when there was money over in the budget, and I said, can we not have an X-ray machine, because we didn't have one. Oh, we need an X-ray machine. Actually a pan machine would be really cool, but just an X-ray machine. No money for that, because they had to buy blankets or something, and they bought a whole lot of blankets. So our patients used to have to go down to the radiology department and have a lateral taken. I couldn't do intraoral. It was so frustrating to work under those circumstances. So I hear the pain of the people who are having to experience that. And we need to help the community and the frontline workers.
So in essence, Prof, you're saying that you should look at multi-sectoral collaboration from all facets, especially to help our health professionals who feel that they can do more in the stream of research, in the stream of policy where they work.
And there's so many things that they come across on a daily basis. This is an irritation to me, because we buy instruments. And I've seen it even here. Well, we've known. We take them out. We go and extraction forceps. I don't know where they buy these things, but they're rubbish. They twist off and they break the tooth, and they break in half. Someone needs to hear from the guy who's working with it. Hey, it looked nice. I remember when I was at Hammanskraal, the military, for some reason, were the suppliers of dental equipment to all the hospitals. And I remember getting in a little car, driving all the way to Pretoria, because I didn't want to order from a catalogue. I wanted to feel that thing in my hand. How's this thing going to work? And I was a little junior dentist who knew nothing, and we had a lot of time, ordered a whole lot of stuff. And it was lekker. It's probably still being used. Decent forceps. Yes, they might cost a little bit more, but you know what? They work better. And you can always buy an L cheaper, and I'm not talking about tender fraud and all the rest. I'm just saying, the impact from the person on the ground is so important. He knows she knows what it's like to use this particular material or instrument, and say, you know what, it looks like the same thing, but it really doesn't flow into the fissures like the other one does. Could we not? And if enough people could talk, we can influence the managers who make these decisions and improve the service. So, but is it research? Well, yes, in a sense. He's counting the number of times the forceps broke compared to how many times before. That's research. It sounds stupid, but it's something minor, but it can lead to an improvement of the service and a better, keep the staff happy and have them go crazy.
Exactly.
Imagine if we introduced community service, and we look at the motivation for community service. It was to encourage people to work in rural areas. I've got a friend and colleague who, I think it's actually her birthday today. She wanted to stay in a clinic where she was working, will remain unnamed, up on the West Coast. After ComServe, she wanted to stay on. Please, please, please. She'd done a fantastic job there. No, it's a community service post. You can't stay here. But was the object of the effort not to get a person, introduce them to a rural setting, and here they want to stay? Well, cool. Let's appoint a ComDent somewhere else. And keep that one there, a ComServe somewhere else. Keep her there, because she was passionate about the community. They loved her. And we lost her. So that's kind of crazy. We need to speak out, and shame that people are suffering out there.
No, true.
The poverty, you see it on a daily basis, and you work with these patients, how they struggle. We need to do something to help them. But I think the Public Oral Health Forum is a very good forum to discuss some of these things. No marketing. But take it further.
Thank you so much, Prof. Barrie, for your time for
Are we
today.
finished already?
We're almost done. Prof, is there anything else you would like to add before we close today? before we encourage our other John Snows in epidemiology and data collection.
Yeah,
Is there anything you would like to add that might also just give our public oral health professionals a bit more extra motivation, you know, to actually make them feel that, you know what, the work is valid, the work is appreciated.
Yes.
We on the coalface, we do more than enough.
Yeah.
What else can you motivate them, Prof,
Well,
to get involved in research, not just research and
No, no,
policy,
I
but
hear
more
you.
in the public health stream?
Yeah, and it sounds bad being a academic, sort quote unquote, to say that don't think of it as research.
Yeah.
Think of it as asking the interesting questions that can lead to a better service for yourself and for your community,
Sure.
the patients. And keep asking these questions. What if? Why can't we? Shouldn't we? Bounce it off others. Doesn't have to go in a big fancy journal article or master's or PhD. Just ask those questions. The satisfaction one gets from deciding, you know what, I think it might be better if we reorganized the waiting room, for example. You know, small stuff. But ask people, what do they suggest? And they'll say, you know, they come here early, but early people have to sit in that cold corner over there and all the rest. So a small way of just changing it around. Ask people. That's research.
Correct.
But it's small stuff that makes it nicer for patients, and then happy patients, happy
outcomes.
they're more likely to listen to you. They haven't been sitting freezing cold corner for a couple of hours.
Or asking patients about how long do they wait, patient waiting times and things like that.
How can we improve that? There's all sorts of stuff. It doesn't have to be a big research project, but it is research, but it leads to better outcomes. Everyone happy, and I'm encouraging them. You go for it.
Thank you so much. Prof. Barrie, thank you so much. We're very, very, very happy to have you with us.
That was fun.
And if you have any more questions or anybody would like to post something on our Facebook or our X page, you're more than welcome to comment at the bottom. And thank you, Prof. Barrie. We will always ask you again to come.
It was fun. It was fun.
Thank you so much.
Thank you for having me.
Thank you.
Bye.
Bye.
Bye.